Good evening and welcome to OpenLine. We are talking about lung cancer today, or this month. November is Lung Cancer Awareness, and a really cool thing, out of all the guests we have Kathy, who is a lung cancer survivor, and I know you touched base being involved with these two doctors to your left, really helping save your life.
Yes.
Tell us how it all kind of started, and what was that treatment like, and how long did you have the cancer?
Actually, I had the cancer, well, I don't know how long it was there before it was discovered, but it was Dr. Grogan removed it quite rapidly. Like I said, I heard about Dr. Massian's trial on the radio. I went in, had the test done. It was a bronchoscopy, a CT scan. They did the nose brushings. They basically...
Was that painful? Nose brushing?
No, I was out. Yes, no, it was under anesthesia.
And so, as far as the healing process, smooth?
No.
No.
No. I've always kind of had the philosophy that, I can survive anything as long as you give me sufficient drugs. Unfortunately, they were giving me drugs, but it was probably the most painful thing I had experienced.
And did you smoke?
Yes, I was a smoker. I was trying to calculate the number of years. It was probably somewhere between 30 and 33. I did quit many times. But when I started smoking as a teenager and really started smoking regularly when I was a freshman in college, they didn't think that smoking was dangerous the way that it is now.
It was advertised then.
I can remember back where it would be recommended for, if you had allergies, if you had hay fever, oh, smoke, it will get rid of it. I mean, it was really, and by the time I had been smoking for 10 or 15 years, I mean, the addiction is there. And it's very, very difficult. It's very real and it's very difficult.
Oh, times have changed, right, Dr. Matt?
The times have changed. Although the times are not perfect, we still see a lot of advertisement for smoking, even in reputable journals. So I think it's not perfect, but we made a lot of progress. And
what you were saying earlier, a part of your tumor was donated for research.
That's right.
So what's that being used for? As far what exactly are you pulling out and hoping to find from that piece of tumor?
So Kathy was generous enough to consent to a research project where the thoracic surgeons, Eric Grogan here, provided us with a specimen of our tumor. And with the tumor, we're trying to understand the composition of the tumor. We know now that each lung cancer is a very different tumor from one person to the other. There is a lot of differences between people, and we're trying to understand this at the molecular level. Why do we do this? Because we know that tumors are eventually driven by some specific genes that encourage the tumor to grow. And if you identify the drivers, so to speak, you can try to hit the drivers and use some therapies that we call targeted therapy, because they aim specifically at the driver and eventually shrink the tumor. Now, with the help of Kathy, we're able to do detailed analysis at the genomic level and understand not only the heterogeneity in the tumor, meaning the differences of the tumor composition at different spots of her tumor. Her tumor was about an inch in diameter. And we also now understand better how the tumor grows from a single cell to multiple cells and different populations of cells, like a tree would grow from the trunk and make branches up. So we now understand better the composition of the tree, so to speak, and how to try to prevent the tree from growing or to cutting the tree altogether.
Dr. Grogan, he mentioned therapy. You also briefly mentioned about invasive techniques.
Sure.
Explain more. What do you mean by invasive technique?
Well, I mean, to do a lung cancer operation does require for the standard of care to be done to take usually a section or a lobe of the lung. And so that is an invasive operation. And 20 years ago, that would have been a very large incision where we had to spread the ribs, and it was extremely painful. And as she said, even now, though we can do it through minimally invasive techniques using the scopes and the cameras, and many times using very little small miniature incisions, it still is painful because we're doing it between the ribs. But it has changed immensely. I mean, we can now make diagnosis with less invasive techniques, with needle biopsies, with bronchoscopies, with special techniques called navigational bronchoscopies. We can localize very small tumors where we can go in and inject material to help us find these small tumors. And then we can use less invasive techniques with scopes and cameras so that we don't have to spread and crack and move ribs to be able to get them do the appropriate cancer operation and the appropriate staging operation. So,
And as a surgeon, I mean, will technology improve? Do you see that improving at all to make it even easier than what it is now?
absolutely. I mean, our surgical techniques are continuously evolving. I mean, we've added several new techniques where we can help, like I said, localize these small little tumors. There's other techniques such as robotics that sometimes are used in these situations, so which can help. And then our technology is improving as well. For example, we use staplers to go in through miniature little ports which staple off the blood vessels and staple off the airways and prevent us from having to really make these large incisions. So the technology really all around lung cancer is improving and evolving and allowing us to do more through smaller incisions and do the same good high quality cancer operations. And the recovery is improving from that. People's length of stay is much less than it used to be. It allows people to get home quicker and recover much faster.
And by the way, for anyone watching, obviously, if you have any questions, feel free to call us 615-737-PLUS. Even if you have a story of your own treatment or of your own story, please, we would love to hear that as well. Dr. Macion, I know you also mentioned about something, hopefully I'm saying this right, immunotherapy.
Yes.
Did I say that right?
Yes,
Okay,
you said
good.
that right. Immunotherapy. This is a revolution in the care of patients with cancer in general, and particularly applicable to lung cancer. So the concept is not very difficult, but if you think about cancer cells, they have ways of eventually suppressing our immune system. Our immune system should defend us, correct? The cancer cells manage to suppress it. Now, we managed to develop new therapies that wakens the immune system to attack the tumors again. And we have seen in the recent past tumors now at the very advanced stage having their tumors controlled by this immune system that's again attacking the tumor and controlling it for months and now even years. It's a true revolution. I think that all of us who are in the middle age are likely to get some cancer later in their lifetime. Most likely we're going to be...
That's scary.
It is scary.
That's
but it's
alarming, but it's obviously the grasp
It's
of
a
the
reality.
yeah.
Unfortunately, 1 in 3 men will get some type of cancer, 1 in 3 women as well. And so if you think about this, we will benefit from immunotherapy and some combination of these different therapies that uses our own immune system to defend ourselves.
And I want to mention your center is the Vanderbilt Ingram Cancer Center. And so you're also saying, though, that your clinic, an essential opportunity for what's ahead in awareness and treatment.
That's correct. I consider my clinic as not only an area where I need to provide excellent care, to teach, because it's a teaching institution, Vanderbilt is a university medical center, and also it is essential for us to engage in research. How do we make progress in medicine? It's through research. So in my mind, I consider very much the clinic as an opportunity to engage patients in research. I'm very proud to say that at the Vanderbilt Cancer Center, up to 17% of our patients engage into some clinical trial during their visits at the cancer center. And this is a remarkable statistic compared to about 3% nationwide. I think this number needs to go up. And as we all advocates, like Kathy was, at a very difficult time of your life, thinking that you're dealing with a new disease called cancer, that's scary. But if you're proactive about it and you're generous enough to share some of your extra tissue that otherwise would go to waste, it could make a big difference for yourself and maybe more likely for others.
Kathy, how are you doing now? How are you doing nowadays?
Next Friday is my 5th anniversary, cancer-free. I'm doing quite well. I did develop
We need some balloons, or just a little bit of hand.
Or a hand clap.
No, we could do that. That's worth celebrating.
Absolutely. I did want to testify to something about Dr. Grogan and his skills as a surgeon. My scars...
Hold on, this is his first time on TV. He might turn a little too red.
I have 3 very small incisions. And I think at the time, he thought they were the smallest that he had done so far.
And how small is small?
Well,
Less than 2 inches.
And was that already using that invasive technology that you were referring to?
yes, that's doing the minimally invasive lobectomy technique that we did. And you know, sometimes if we do not have a diagnosis going in, which sometimes that's the case, then we will take out a small piece of the lung tissue and we can send that off to the pathologist at that time, and they can tell us whether it's cancer or not. And then at that time, so that you don't have to come back at a later time, we can perform the cancer operation at that same setting. And so that allows us to really do sometimes the diagnosis and the treatment all at the same time.
All right, we have Taylor on line 1. Taylor, if you can hear us, welcome to Open Line. What is your question?
Thank you. I appreciate the program. I got started watching a little later, so this may have already been asked.
Join the party.
Is the high-dose CAT scan the best way to initially find lung cancer?
Yeah, I can probably take this question.
Taylor, thank you.
Sir, for asking the question. Actually, it's low dose CAT scan. So low dose of radiation that people get. It's about 1/10 of the regular dose of a regular CAT scan. But yes, so far there is only one way that we know is efficacious at detecting the disease early, and that is the CAT scan that you're talking about. We don't offer it to everybody, but we offer it primarily to people at high risk, meaning they're over 55 years of age and all the way up to 80 years old, and people who have smoked for, let's say, a pack a day for at least 30 years and have quit less than 15 years ago. So if you meet these criteria, you fit into this.
And can I say one other thing? I mean, that's, although we are worried about radiation, that's less radiation than what we get from just living for a year. So the low-dose CT scan is less radiation than you and I get from just walking around in the course of our days through the year, that we get from the sun and from probably being in this room.
And Dr. Massian, for any information, I'm sure if anyone's watching right now, as far as reaching out, even for you, Dr. Grogan, what's the best way? And then we'll have this information again at the end of the show, but I want to make sure at the bottom of the hour we have that out there.
So the Vanderbilt Ingram Cancer Center has a screening program that you can find on vicc.org. We also offer clinical studies that you can engage and be followed for a total of 5 years. And the number to remember is this 1-800 number, 1-800-811-8480. And you will get access to a person on the phone who will help you navigate through your potentials of enrolling into screening for lung cancer.
And no worries, we'll have that information again at the end of the show. Stay tuned, and again, if you have any questions, feel free to call us. We have a great expertise and, of course, a cancer survivor. So if anyone wants to relate or have any questions as well, please call Open Line. We'll have more after the break.